Hello, everybody, and welcome to this special Cytology get-together that Kate and I have organized for all of you. It has been a very tough year for all of us, and we wanted to do something to cheer you up. And as you can see from my hat, my Christmas jumper, and Kate as well, we decided to do something quite fun, and we hope you will like it, and we hope that you are dressing Christmassy as well right now. I love your hat, Kate. That's
Oh,
amazing.
thank you. Thank you. It's standing up quite nicely.
So we have chosen some cytology cases. Kate has chosen two cases. I chose two cases as well. There is a sort of a common theme behind that we are going to unveil. And what do you think, Kate? Shall we start? Shall we?
Yeah, yeah,
Yeah,
yeah. Let's go ahead and get started. And you're going to go first, and then I'm going to come in after, and I'll
yeah,
kind of introduce myself before I get started. But I
super.
just want everybody to admire the background. I just have the lines, but look at this gorgeous background you got here. The tree and the nutcrackers.
The
So
Christmas tree.
festive.
Yeah, however, I've seen behind your window that you have a lovely
Oh, yes.
countryside kind of look because outside here it's just typical of the UK, a lot of rain and
UK. Yeah.
UK, nothing
A little dreary.
yes, exactly. So let's see if technology is with us, and let's try to share the screen. So you tell me if you're seeing my PowerPoint. Is it working?
I see it.
Yeah, fantastic.
Hooray!
So let's start. So first of all, I mean, we have kind of skipped the introduction, but as Kate said, we can introduce ourselves when we start the our cases. My name is Francesco Chan, even if I don't look very professional in this moment. I'm a clinical pathologist and work in the UK for the Laboclin Group. And as some of you know, I am the creator, the founder of the Veterinary Cytology Facebook page. And let's start with the cases. I'm super excited, so let's
Yeah.
go with the proper cases. So, as I said, I chose two cases, and I kind of wanted to make it sort of Christmassy, even if I have to be honest, there is not much Christmas in these cases. As you can imagine, they're a little bit sad stories. And I chose a dog and a cat. And as you can see from the title, the common theme is muscle tumor. So I call it, it all started with a muscle tumor. So once upon a time, there were a dog and a cat. And let's start with, no, actually, we start with the dog, but I have a disclaimer. And the disclaimer is that, as I said, these are both quite sad stories. And I have to be honest, I'm sure that Katie, you kind of agree with me, or I mean, I don't know, but often it's a bit sad, but the disease severity is a little bit sometimes proportional to the excitement for the case that the pathology has. And I think that this is not because we are bad people. We are not bad people at all. It's just that I think that we are very, I don't know, I feel very fascinated by the biology of tumors. And so that's why sometimes we get a little bit overexcited.
I'm glad you mentioned that because I thought about starting my part with that too, that I get overexcited about these things and it's not because I don't care about the animal. Of course, we all went into veterinary medicine because we care about animals. So, but I might squeal a little bit when I'm talking about mine, and it's not because I don't care about the impact of it on the animal, but the pathology is very cool.
Yeah, exactly. I fully agree. Thank God now it's not a big issue, but it was a problem when I was working practice because I was working in practice and doing some cytology. And when I was chatting with the owner, I had to kind of calm down a little bit.
Yeah,
So,
that's different.
yes, it's a little bit different. Now, when you talk with vets, it's a little bit more easy.
Yeah,
So,
yeah.
as we say, the severity of the disease very often goes together with the pathology excitement, but don't judge me, don't judge us. We are not bad people. Okay. So the first case is a dog a boxer, which already says lots of things, and 11 years old, female neutered, and this dog had a cutaneous mass on the left hind leg and also an enlargement of the left popliteal lymph node. And obviously, what can you do if not the cytology on all of these? So the vet took FNAs and submitted the cytology to me. And I started, and we start together with a cutaneous mass, which is maybe the little bit less excited, I would say. And this is, I just chose one picture at high power field. I'm sure that lots of you that you are watching now recognize these and you're kind of smiling. Maybe some might not be very confident, but this is I would say, typical muscle tumor. So discrete population of cells, as you can see here, all, my arrow doesn't work, but anyway, all round and individual, and they have those typical magenta purple granules that sometimes they also obscure the nuclei. And the nuclei, when visible, they're quite round, paracentral, and there is a little bit of atypia, but it's not too severe. And also in the center, you can see, I'm not sure why the arrow doesn't work. Technology is not with me now. But in the center, you can see that there is a eosinophil, so a cell shaped like a neutrophil with some orange granules that often accompany muscle tumor. So diagnosis of muscle tumor, relatively straightforward. And I think it's one of those diagnoses that it's nice, between difficult cases, sometimes to have a muscle tumor, a lipoma. It's like
yeah, a little break.
Exactly, a little break. And this lesion was removed surgically, was submitted for histopathology, and the diagnosis was muscle tumor. And they also did a grading, so it was a grade 2 Pat-Naik and low-grade QPL, and with clean margins, so not too bad. However, if you remember, there was also this enlargement of the lymph node, and that was FNA as well before obviously going into surgery. And I was expecting either a reactive lymph node or a metastatic muscle tumor. So I was like, okay, let's have a look. And then I was surprised because every now and then I think we get surprised. And on this case, I'm really curious to know what you think as well, Kate, because I'm still a little bit puzzled by this case. So this is a picture at a low power field of the lymph node cytology, and obviously main population of lymphoid cells, mostly small in size. There are a little bit of intermediate and large, so mixed, but mostly small. So some sort of reactive lymphoid hyperplasia, I would say. But then there are a few cells that definitely look, some mononuclear cells are quite large and quite atypical. And I was thinking, what are they? Are they macrophages, histiocytic? What the hell are they? They definitely don't look like muscles. And then another one still at low power here as well. And then a little bit at higher power. Still, I would say sort of histiocytic, macrophagic kind of appearance. There are two mitoses in the center. We know that mitosis can be seen in macrophages as well, but still quite a few. There is one plasma cell at like 11 o'clock. And then by looking around at this case, I start seeing some, I would call it monsters, not very scientific, but they look like monsters, like this big one, this giant with this funny shape nucleus, and then even worse, something like that.
Oh wow,
that's quite big, isn't it?
Those are the fun ones.
Yes, yeah, exactly.
You start going, what? Whoa.
What? Yeah, exactly. And then yeah, it's not a good news, sadly. And so I was quite puzzled by this case because yeah, those cells were quite unexpected. Even if I had histiocytic, macrophagic morphology, they didn't convince me of traditional macrophages of histiocytes. What do you think? Do you have any, I don't know, any idea?
Yeah, I mean, I would have initially looked at this and thought, well, is this just crazy metastatic mast cell population that doesn't have stained granules, although they don't really look like that. Even when the granules aren't there, I think we can still kind of pick up on some features that make us think that they're probably metastatic mast cells, like color the cytoplasm. And yeah, these don't look like that. Yeah, I would be thinking histiocytic.
Yeah.
Just based on everything that you're, I mean, the monster cells especially, but yeah, this would probably be one that I'd be sitting on for a while and end up breeding out malignant metastatic neoplasia, and
that's exactly
who knows.
exactly what I did, because was obviously the last case of the day, as always happen, and I thought, shall I report it now or shall I wait tomorrow morning? And I thought that let's wait tomorrow morning, that things may be clearer in my mind.
Yeah.
The morning after, they were not clearer, but still at that point I had to report it. And yes, I said that there was no evidence of metastatic muscle tumor, and there was some reactive lymphohyperplasia, but these cells were atypical, and I put histiocytic sarcoma as a likely differential, even if the clinical history was a little bit weird. And so these were the differential that I included. So histiocytic sarcoma, pleomorphic sarcoma, or sarcoma of some sort. I put as an unlikely differential a pyogranulomatous lymphadenitis or beta granulomatous, but again, they were too atypical to be macrophages. There were no other inflammatory cells, no neutrophils, and nothing else. So
yeah, I always do that too, though. I sit there and think, am I going to give this animal something malignant, and these are just macrophages? But then you find those huge ones and you think, oh, thank you. Thank you for making this a little more clear that, sometimes we still will include it on there, like you're saying, that it's like, that's not what it is.
Exactly. Also, nothing that infectious that came in my mind. And then, it was a dog that lived in the UK. In the UK, it's a little bit a sad country for infectious diseases. So that was not in the list. So the lymph node was removed at the same time as the skin mass, and the histopathologist sent me some pictures and essentially confirmed everything we have seen. So again, population of lymphoid cells, quite mixed, mainly small, and these giant horrible cells were present in the histo as well. There were also some multinucleated elements which I didn't see in the cytology. We also decided to do immunohistochemistry. I thought, why not? And we did lymphoid markers, and these larger cells were negative to all lymphoid markers. They also did a toluidine blue, just to rule out some really typical mast cells, and was negative. And these larger cells were positive to CD18 and IBA1. So maybe for those that are not very familiar with markers, CD18, it's a marker that is positive in most leukocytes, but particularly positive in histiocytic macrophagic cells. And IBA1, it's a marker that is very specific for, again, histiocytic macrophagic cells. And talking with the anatomic pathologist, they said morphology and immunohistochemistry results are really strongly suggestive of a histiocytic sarcoma. So we thought, poor dog, yeah. I mean, with a muscle tumor that actually was a grade 2, so not too bad, but with a histiocytic sarcoma, that's never obviously a nice diagnosis. So yeah, that's why it was a bit of a sad story.
Yeah.
And so the probable diagnosis of the lymph node was a probable localized histiocytic sarcoma, because the vet did a full CT scan and ultrasound, and there were no other abnormalities. So possibly it was a primary histiocytic sarcoma of the lymph node, which is quite weird.
Yeah. I've never seen that. That's
me neither.
That's interesting. Well, now you have. Now you could add it to your list. I've seen that before. Yeah, that's so interesting. I've of course have seen histiocytic on the skin and localized to like just skin lesions, and then obviously eating up the whole animal. But wow, just in the node.
Yeah, in the node is it's very odd. So I've been a little bit of a stalker with the vet that actually then I found out that was also the owner of the dog. Always happens, the worst cases are, owner is the vet and he's also the owner of the practice, and Anyway, dramas. Let's leave those outside. And just to summarize, in September 2018, FNA, then the biopsy and the histology 1 month after. Then at some point, because I called them a few times, I was a bit of a stalker, was a full body scan, was negative. I called them in December 2019 and they told me everything is right, don't call us too often, that might be a bad luck. And then in April 2020, I called them, and unfortunately, the dog was put to sleep because developed some multiple masses on the bladder and the lungs. The owner, the vet, didn't want to do any investigation, so we don't know. Was histiocytic sarcoma that spread, possibly, likely. Was the muscle tumor that was previously removed? Was it different tumors? Who knows?
That feels like a pretty good amount of time, although I guess it's only about 1.5 years, isn't it?
Yeah.
But I don't get a ton of follow-up, but I would think that most disseminated histiocytic sarcomas are blowing up faster than that. So I mean, it's good that it maybe just because it was localized, it was able to get
exactly
under control.
Exactly, because I was looking in the literature, then I'm going to show, and the localized cases might stay localized for a while, and by the time they become disseminated and the dog, die, can have a survival that is a little bit longer. So, so I've done a little bit of a search in the literature, and there was this interesting paper of 73 dogs with histiocytic sarcoma, and they had 5 that involved the lymph node, and 1 had lymph node as a primary site. So yes, not common at all, because that was my first one, but it has been reported. And just a few information for people that are maybe not very familiar with these. Histiocytic sarcoma is a malignant tumor that originates from the interstitial dendritic cells and can be localized, and as our case was, or can be disseminated. There are some predisposed breeds. This was not one of those, but we know the boxer usually, they go along quite well with tumors, sadly. The localized form, usually they are mainly at the level of the bone joints, spleen, or at the level of the skin, but can be seen very rarely in the lymph node. And actually, if any of you that you're watching this video has had any experience of a primary histiocytic sarcoma in the lymph node or other unusual location, let us know, because I think it's very interesting. So treatment-wise, not my area, but I was just reading. Usually it's surgery for the localized treatment, and sometimes often actually adjuvant treatment. And they localized, they have a better prognosis compared with the disseminated. And there has been some treated cases of periarticular and splenic localized sarcoma that survived for years. So maybe this was one of them. Who knows?
Yeah.
So this was the
very interesting. Yeah, that's I would have been very surprised to see that in that node too.
So this was the first sad story of the day. Sorry for we say that we want to do this round to cheer people up, and then we present these cases, but I think they are very interesting. So
for sure,
let's take that. This article that I'm sure that you have read.
Yes.
I personally strongly recommend to everybody that wants to know something about histiocytic disorders to read it. It's also a free download on VetPath, so you don't need to pay for it. And I think it's a fantastic review from every point of view: cytology, histology, immunohistochemistry, but also clinical and treatment-wise. I find it amazing, a really good one. So it's a master read, I would say.
Yes, I agree.
And second and last case from the dog. Now we go to a cat. This was a cat, domestic short hair, 8 years old, male, FIV positive. So it's not a good start. And I'll tell you a story in the way I got them, because as often happens, you don't get the full story. I'm sure that it happens to you as well, or not? Yeah.
Unfortunately, yes. And I have a point about that in one of my cases for making sure we, pay attention to histories.
Because sometimes I think that when we present cases, everything looks so nice and clear and straightforward, and then obviously that's not the way things were presented to us. So this cat had a rapid onset of abdominal effusion, and they submitted the cytology of the effusion, and also they found some skin lesion when they were placing the jugular catheter, and they did the cytology of that as well. So cytology of the skin lesion, very straightforward. I'm sure that you are all guessing what's going to be, and it was a muscle tumor.
Oh, so pretty.
Yeah.
Little kitty cat granules.
I know, yeah, exactly. So pretty much the same. So well-granulated muscles. As Kate said, they have much more fine kind of granules, and there are no eosinophils here. I think they are not present as often as in dogs usually, isn't it?
No, yeah, I don't see them as often at all.
Yeah. And if I can
and I always know that because when I put in my template for mast cell tumors, I have to always erase the eosinophil part because
exactly.
they're usually not in there. So
exactly. One thing that is interesting thinking about muscle tumor that I haven't seen it much, but I often read it in books. They say that in cats with muscle tumor you can have small lymphocytes.
I've read that. I've seen that brought up before too, and I don't know that I've experienced that. If I have, I haven't noticed.
Yeah.
Have you
seen
them infiltrate?
Yeah. I read it, but I've never seen it. Or if it has happened, maybe there were one or two lymphocytes, but maybe those were just
there. Yeah.
And then the fusion. So the fusion had a total protein of 37 gram per liter or 3.7 gram per deciliter, and a nucleated cell count of 58 million cells per liter. So really, really highly cellular kind of fluid. So the guess origin initially were, is he a neutrophilic exudate, a sort of inflammatory lesion, or is he a tumor? Who knows? Now let's see if I can do it because I have the digital slide, but I think it may be a little bit tricky. I think I will go with the pictures. Is it okay? I think it's more straightforward because the pictures are quite clear. So this was the fluid at low power because it was the digital scan and it was scanned not at really high quality. Quality is suboptimal, but I think it's enough to understand. Really high cellularity. This was, I think it was the direct, so really high cellularity. You can already see likely a prevalence of neutrophils, and there is definitely something else going on, some unusual material. And let's go at slightly higher power. And again, neutrophils, there are some macrophages, and then there is this material, this sort of crystalline kind of material, yellowish in appearance, non-refractile, that was present both in the background but also within the cytoplasm of macrophages, and that rang a bell. What does
I know the answer, so I don't want to say it. But I would not have known. I would have had to sit on this for a minute and probably ask other people that are smarter than me what they thought it might be. Because that's gorgeous. But yeah.
I was a little bit because now I'm like, oh yeah, of course it's this. Right. I have to be honest, it was not so straightforward because when I've seen it, I had often it happens to me that I'm like, I've seen this already somewhere, but I don't know what it is, and I've been thinking and thinking, and then I was chatting also with two other colleagues, and then something happened. Something happened in our brain, and we thought, oh, this looks like barium sulfate. Possibly, but in the clinical history, we didn't have any information regarding that. So we said it's clearly a neutrophilic exudate. There is some exogenous material, and we raised the question: could it be barium sulfate? Have you missed something from the clinical history? Of course, I did. typical.
Yeah, those are always the not fun for the patient, but fun cases for us. In my like those are the ones that I love because you can say, it all makes sense now. This all makes sense, and I have one of my cases is similar like that. But yeah, that's very cool. So yeah, what did they say? What had happened?
So our cytological interpretation was a probable barium peritonitis that then actually was confirmed because by talking to them, they said, oh yeah, sorry, we forgot to tell you that 20 hours before, because the cat was vomiting and has been anorexic for a little while, we were suspecting a GI obstruction, so we had performed a barium study. And so I thought,
Wow.
great, now kind of everything
Yeah.
made sense. So it's a barium peritonitis.
Oh,
So I was happy that I made a diagnosis. I was a little bit concerned about the case and the patient
yeah.
because that's not a good, it's not a good news.
Then because there was there's I don't know if it's been recent or if I'm just making this up in my head, but in Vet ClinPath, wasn't there a publication on this? So what's your diagnosis?
Absolutely, yes, yes.
Yeah.
That's
Okay.
why, and that's why.
That's why it popped in your head.
Yes, because it was a case that I remember I studied for my board because I think it was in the 5-year reading list that everybody's afraid
Yeah.
of. I have a picture of that case report actually. So just to explain you what happened with this cat that sadly didn't survive because was put to sleep because the effusion worsened, quite rapidly actually. So this cat originally had a visceral muscle tumor. That's where all started. This muscle tumor likely caused some cutaneous metastasis, which is what we identified by doing the cytology in the lesion in the jugular area. The muscle tumor was localized in the GI tract at the level of the pyloric antrum, and in that level, in that area, there was also a ulceration, and that's obviously where the contrast material, managed to go through and reach the abdominal cavity, and the anorexia and vomiting were probably due to the histamine contained within the muscle granules, because obviously visceral muscle tumor, these systemic clinical signs are quite common. So because of all that, the cat developed the barium peritonitis. So that's the sort of
no way the vet could have known and prevented that. Just bad luck, I guess.
Yeah, exactly. It was bad luck, really, really bad luck, and they did everything they could to reach a diagnosis and to save the cat, but unfortunately, it didn't work. So just a very, very few information. Visceral muscle tumor in cats, very, very common. According to some books, they say that they are 50% of all muscle tumors. And they are mainly localized in the GI tract, more often in the intestine, more than the stomach or in the spleen, and the skin can be involved too, secondary, or can be an unrelated muscle tumor. And often, like in this case, they can have systemic clinical signs, and especially for the GI one, the prognosis can be quite poor. And then the barium peritonitis that I thought was quite interesting was my first and only barium peritonitis I've ever seen. I mean, now that I've seen it, I'm okay with it. I mean, because I know that it's quite bad for the dogs and cats, so I've seen it enough.
Yeah.
And it's obviously very serious and life-threatening condition, especially when it's combined with the bacterial peritonitis secondary to ulceration or perforation. In this case, we didn't see any bacteria. No culture was done because, there was other problem at the time. The emergency was, that was other priorities, I would say. And was interesting, the pathogenesis, which is quite complicated and not completely understood, but one of the things was the barium sulfate that can cause exudation of extracellular fluid, and that can cause hypovolemia and hypoalbuminemia. And also, obviously, it's a irritant substance, so it can cause inflammation and also fibroblastic proliferation and neovascularization. So it was quite interesting. And in terms of publications. The one on the left, it's the one that you
That's
mentioned,
the one.
Kate. Yeah, exactly. Because I had they look a little bit different. They're more yellowish
Yeah.
than in the publication, but kind of similar shape. And that was a water
Mhm.
diagnosis. But I find them they're so useful. Those short articles. These
Yes.
are quite very, very handy. And then I found, especially if there is any clinician that is listening right now, there is this publication, I think it's also free download, that is called Barium peritonitis in small animals. And it's a sort of review, and there is a lot of information also regarding treatment. So it's too much for me. But if anyone is interested, also how they should be treated and follow up was very, very detailed. I kept all the part, but I'm sure that for some people can be very, very interesting. So
Mhm.
that was my barium peritonitis. That was
Oh,
quite.
wow, what an interesting case. Yeah, that's nice how it all fit together and made sense. And even though it was a sad outcome, obviously there was an answer as to what was going on. I'm glad they sampled the fluid, and because that would have been, you know, I would have been looking at that thinking, why does the cat have fluid? Obviously, I would have put those in two different categories because I wouldn't really. I've seen neoplastic effusions with mast cells, but in dogs, I haven't seen that in cats from
Get
their
me neither.
uh, so I wouldn't have been thinking, oh, this is going to be filled with mast cells. So I'd have been wondering what in the world, why does this cat have an effusion? Also, obviously, it would have been something, or I would have thought unrelated. Maybe the cat's, something
Yeah,
else going
exactly.
on. But
Maybe just unlucky like the dog that I showed you before.
yeah, yeah, right, right.
So
Yeah,
yeah.
wow, very interesting.
I think it's
I
nice
love
that
love
there
seeing
are
that.
these cases that, with cytology, you're able to find out some clinical information. Like it happened to me, it was like, I think it was like 2 years ago, that there was a gossipy boma, an effusion in the
Mm,
abdomen, and there was these macrophages with this sort of cotton fiber, so some structure that looked like cotton
hmm.
fibers. And I spoke with the vet and say, "Are you sure that has this dog had a previous surgery?" Yeah. Why? Are you
Oh
sure that there
no.
is nothing left in? No, no, I don't think so. Then did the
Oh.
imaging and then explorative laparotomy, and there was a gauge left in
Mm-hmm.
with a lot of granuloma, those inflammation around. And I thought, oh
Mm-hmm.
wow, so cool that with cytology we managed to track down what has
Yeah.
happened before.
Yeah, that's the best part of what we do is the whole mystery part. I mean, it's nice to get our like you said, our lipomas and our mast cell tumors just have a little break, but these ones that are kind of more mysteries and helping figure out what's going on, and it's really cool when it completely changes the course of the case. When they're going in one direction, which isn't, it's not that the clinicians like doing anything wrong, like they're going in a direction that's appropriate, but then when they do what they their due diligence and take the cytology, and then we help them steer the ship in the correct direction. That's always even if it ends in euthanasia. I mean, that's the appropriate treatment. Otherwise, we
Yeah.
might be continuing trying to do something, when it's not appropriate. So yeah, I love it. That's
Yeah.
great.
And I think it's also when the clinician think, oh, so the clinical pathologist is actually useful.
Yeah, right, right.
So
We don't
sometimes,
just put correlate clinically on every single thing.
exactly. Sometimes, we can make the difference. So I think we need to be
Yeah.
quite proud of that, I would say.
Yes. Yes.
So those were my cases. So
Great.
now let me share with you. Uh,
I love your cartoons, by the way.
you like
I don't,
it?
or they're not even cartoons. They're like beautiful art.
Yeah, it's a friend of mine that she's an illustrator, and so
Oh, they're
she
so
made it for
nice.
me. So that was quite fun. So let's now see if technology is with us. So yes,
Oh,
I
I pressed share
make
screen on
you
mine, right?
host, and so now
Okay.
you are in control of the system. Let's see if it works.
Oh, I'm scared. I don't want to mess it up. Okay, let's see. Desktop.
It's amazing
I think it's
how
gonna.
now everybody know what's Zoom, how to use Zoom. So things have changed so rapidly in
Right,
one
right.
year.
I still fumble through it though.
Yeah, me
Can you
too.
see? Can you see mine?
Yes, I can see perfectly.
Okay. Yay. All right. Well, good. Well, thank you for inviting me to do this round. It's super fun. We were just chatting before we started recording that we feel like we know each other because we're, always on social media and talking and, obviously share the same love for this specialty, so it's always fun to be around other people that get as much out of cytology as I do and that we do. So, and thank you all for joining to be part of that and be here for the Christmas rounds. My name is Dr. Kate Baker, for any of you who don't know me, and I have the Veterinary Cytology Coffee House group. Yeah, so that's where I spend a lot of my time, and I think that's it. That's the main gist about me. I just love what I do, so I'm always happy to share it. And I've got a couple cool cases for you guys also. I kind of went off of Francesco's theme about it all started with. So his was it all started with mast cell tumor, and for me, I picked two cases that were it all started with presumptive lymphoma. So presumptive being the clinician assumed it was going to be lymphoma, and maybe it was, maybe it wasn't. I don't know. We'll find out. So yeah, the mystery, the plot thickens. So for my first case, and I was admiring your PowerPoint because apparently we have very similar styles of presentation using little cartoons and pictures. So
because we haven't seen each other PowerPoint. Because we to keep it like a sort of surprise. So
yeah. So we are clearly on the PowerPoint styling same simpatico there. But so my first case is a 3-year-old castrated male domestic short-hair cat, and this is not him, but he's looking quite festive and kind of irritated, as cats typically do. And this cat presented for the history that I got on the submission form was that the cat presented for cluster seizures, and that 2 weeks later, so I'm assuming that means 2 weeks after it presented initially for the cluster seizures, it developed generalized lymphadenomegaly. So that was all the history I was given. And sometimes we get history that's relevant and sometimes history that isn't relevant. That doesn't mean it's not valuable. It just means it might not be useful in the case. So I didn't know where this fit into that at all with my case. Just it's good to include those things though, if you think that there's any potential that some history in the patient is going to be relevant. So that's what they included. Oh, I'm sorry. And then they did include that on their physical exam, all peripheral lymph nodes were enlarged. So that wasn't, that was kind of part of the history that there was a generalized peripheral lymphadenomegaly. So at that point, when you're seeing generalized peripheral lymphadenomegaly, we get nervous about lymphoma, right? So the clinician was concerned that this cat had lymphoma. The cluster seizures maybe were associated with that, maybe not. But of course, lymph nodes being enlarged can be from multiple different things. But one thing, of course, we all worry about is lymphoma.
Yeah.
And the sad little cat is feeling that concern.
He's not enjoying the Christmas decorations.
No, I don't think that cat's super happy to have a hat on. But so they went ahead and took an aspirate of one of the enlarged lymph nodes and submitted that, and that's what I got. And of course, the whole question is reactive or lymphoma. Those are not the only two things that can happen in a lymph node, just reactive or lymphoma, as you and I both know. But that's what we're looking at when we're assessing the lymphoid population. In particular, is it a reactive population or lymphoma? And sometimes it's not easy to tell. We have some that are straightforward, some that are more complicated, some that are clearly reactive and not lymphoma. But I found in cats in particular that they can have lymphoma and their nodes look reactive on cytology. So I am careful with cats now. If I have a suspicious history and that looks like it could be a lymphoma case, and I'm seeing what looks like it might be a reactive lymph node, I still try to make it clear to the clinician that that doesn't. It's hard to find like a way to convey that information that it could still be lymphoma, because I don't want them to feel like the information I'm giving them that it's reactive is not valuable. But basically, if the lymphadenomegaly is not resolving, if it's unexplained, continues to be unexplained, that they may need to do additional diagnostics like histopath or molecular testing for that, to rule that out, to rule out a lymphoma that we're not seeing on the cytology. But in any case, knowing that, but we still want to evaluate the lymphoid population, see what we think about it. So in this case, I would look at the lymphoid population, and I think my arrow is working. Can you see it?
Oh, that's good. Yeah, I can see.
Yeah. You got the short end of the stick with the, well, now mine's going crazy. Okay. So my arrow is kind of small. Oh, when I go fast, it gets big. All right. So I'm learning a lot about my new computer, but yeah, so looking here at the lymphoid population, just for everybody who's watching that may not feel comfortable about interpreting lymphoid populations, I'll just kind of do a little quick recap of that, or tell you how to do that. So here are all the lymphocytes, right? So we've got lymphocytes all over the place. These little green things in the background are red blood cells that just stained funny that they sometimes look green. But the cells that we're wanting to look at are these lymphoid cells. So in a lymph node, in a normal or reactive lymph node, we expect them, it's all about proportions. We expect in a normal or reactive lymph node for there to be a predominance of small lymphocytes. And in a lymph node that's affected by large cell lymphoma, we expect there to be a predominance of large lymphocytes. So all of those things that we learn about anisokaryosis, anisocytosis, all those criteria of malignancy that apply to other types of neoplasia don't apply to diagnosis of lymphoma. So it's really important to remember that it's all just about proportions. So in this case, we're looking at this lymphoid population and trying to say, are the majority of the cells small lymphocytes or are they large lymphocytes? And the way that we can kind of get that gauge is finding a neutrophil and looking at the size of the lymphocytes in comparison to the neutrophil. Now, a small lymphocyte should be smaller than a neutrophil, and sometimes there's ones that are kind of on, the cusp. Like this one's probably more of like an intermediate size, but the majority of these here all over are small. And then we've got a handful of large lymphocytes. So you might look at this and immediately I see people get their eye drawn immediately to the large lymphocytes and go, whoa, those are huge lymphocytes and they've got big prominent nucleoli. What's going on? They're totally okay because they're in low numbers compared to the small lymphocytes. So this node here in this picture is looking quite reactive. And I also have another picture. There's some plasma cells in here too that you can expect to see you don't always see them in reactive lymph nodes, but wouldn't be surprised to. Here's a plasma cell here. And we've also got a couple more plasma cells in this picture here. So this is a nice, pretty, what looks like a reactive lymph node. And so you might be thinking, well, that's kind of boring. Why did she share this case? If it's just a reactive lymph node, like who cares? And the cytology in this one is not necessarily the most exciting part of this. It's just the story about this patient, because so I see it's reactive and I could have just set my report and moved on, but I was thinking, okay, I just want to think a little bit more about this case. Is that where the story ends? Well, no, I wouldn't be sharing this case if that's where it ended. So I took a look back at the history, and I was just thinking about this case and looked back at the history and remember it presented for cluster seizures, and then 2 weeks later developed generalized lymphadenopathy. And then I looked at the submitting clinic, which was a specialty clinic. So I thought, I wonder if this is a neurologist. And I mean, even whether it's a neurologist or not kind of is irrelevant, but the fact that it's a neurologic cat. So it's presenting for seizures. I thought, didn't I read something in some journal at some point about this? So that's a very important piece of history in this case, because I thought, is this cat on phenobarbital? Did they put this cat on phenobarbital when it presented for cluster seizures, and now 2 weeks later it has this generalized peripheral lymphadenopathy? So I went back and I thought, I think there's a paper on this. Sure enough, there is in the Journal of Small Animal Practice, and my memory was on my side that day. And this paper describes a case of what they called pseudolymphoma in a cat that was on phenobarbital. And this cat presented, was a neurologic cat, was put on phenobarbital, and then developed generalized lymphadenopathy, and they did cytology on those lymph nodes, and it was just reactive lymphoid hyperplasia. And so I was thinking, I bet that's what this is. That's just so neat because, if this cat's on phenobarbital, then that's got to be, this could fit. There's other reasons, of course, why you can get generalized lymphadenopathy, but it's a 2-year-old cat, otherwise has no clinical symptoms or anything like that of anything else. So I gave the veterinarian a call. Sure enough, she was a neurologist, and
if it was,
yeah.
if they did the FIV, FLV, or we don't know.
I want to say yes. I would be lying if because it's a couple years old. I would be lying if I said I was 100% sure, but that's a great question. And for anybody who's watching that might be wondering why he's asking that, is because you can actually have generalized peripheral lymphadenopathy reactive nodes in cats that have retroviral disease. And I'm pretty certain that they test it. Yeah. I mean, if it was at the neurologist and they were working it up completely, then I imagine they did. But good question. And so I thought I'm gonna call, I'm gonna check in and see if this cat could be on phenobarb. And sure enough, she said, yep, he presented for seizures, and we started him on phenobarbital, and then this generalized lymphadenopathy developed. And I was like, well, this is so neat because it just all seems to fit. Now, can I prove with 100% certainty, when I looked at the cytology, were the cells going, hey, we're doing this because of phenobarb? No, I can't.
I wish
yeah.
they can talk to us.
Right. I mean, I guess there could be some other reason. I can't, with the scientific method, I can't come to the solid conclusion that's why it was. But the story all fits. And what I would have loved to do was take the cat off phenobarb and see if it went away.
Oh yeah.
But the neurologist was not super keen on that because the cat had seizures, and at that point they didn't know why. So they didn't want to do that so that I could feel better about my diagnosis. Unfortunately.
Yeah.
But yeah, so I don't know. I'd love to actually follow up with them because this has been several years now. So at this point, I imagine unless the cat's still on phenobarb, that they have some kind of follow-up that might support or refute my suspicion. But I really I wanted to highlight this case because, again, even though the cytology is not all that exciting, it's a case that for especially clinicians or anybody really, that because I had forgotten about this, to remember that this can happen. This is a differential diagnosis for cats on phenobarb. And I think, and again, I might be wrong about this, I'll have to go back and look, but I think that there was a report of it in a dog too.
Yeah.
Was there? Okay. Yeah.
Yeah.
So it can happen in
the dog. Yeah.
Do you know what the pathophys of that is? I probably should have. I'm guessing it's idiopathic.
Yeah, I mean, of course, yeah, the idiopathic is always one. It's always one of the differential. I think they were saying that the a metabolic of the drug can act as a sort of antigen and induce a sort of immune response, immunostimulation, non-specific, and cause reaction of the lymph node or something like that.
That sounds good to me. I mean, that would make sense.
Yeah. It's a great case, and what I really like is that sometimes I hear people saying, pathologists report are all the same, and I think they are not, because like a case like this, I think it's a great example that probably most of people that have a little bit of experience in cytology would say it's a reactive lymphodeplasia, but what makes the difference sometimes is like the comment where maybe you investigate the clinical history and you say, oh look, these are the differential, these are the things that the additional test you can do. Oh, by the way, generalized lymphadenopathy is reported with phenobarb. And I think that I have always seen that when we spend that extra time of the, on the report, then it's always useful and appreciated by the clinician, because it kind of helps to create a connection with the clinician and also a sort of trust, I would say.
Yeah. Yeah, I completely agree. And because there's going to be plenty of cases where I don't have a lot of extra things to add. I mean, that reactive lymph nodes happen all the time for reasons that nobody knows, whether, we look more into it or not. But cases like this are, yeah, I agree. It makes me feel good to be part of the team. And even though when you're doing, 60 cases a day or however many pathologists are doing, you don't have a ton of time to
Yeah.
to call and to mull over things. That's what makes this fun. I mean, these are the things that are that we read about, that there's a reason we keep up with our journal reading. Well, I'm a little behind. I just had a baby, but I'm there's no excuse. I'm more behind than 4 months, which is my baby's age. But yeah, I mean, there's a reason we go into this, and I don't know. I just love it. This was one of those cases where it's like your case where you're just like, wow, that really fits nicely. And that's cool to see something in a journal where you just read it and okay, it's there, and then you actually see it. And
Oh yeah.
same for clinicians. They can read about something or hear about something and then they see it and it's, wow, that's really neat. So the neurologist had no idea that this was a thing. And so we talked about that, and she was comfortable just monitoring it at that point because again, the cat had no other reason to have these enlarged lymph nodes. Now, I did tell her, if these are persistent or if the cat starts to develop any other clinical signs, I would look into it more, just because, like we talked about, want to make sure that it's not a weird lymphoma or something that we're just not picking up on cytology. But the story really all seemed to fit in this case, which was really fun.
Nice.
So a couple key points: generalized lymphadenopathy is not always lymphoma. So I don't mean to be, obnoxious with that comment, because of course we all know that generalized lymphadenopathy is not always lymphoma, but there are plenty of other reasons that you can have enlarged, several, I should say, other reasons you can have generalized lymphadenopathy. And of course, like we just talked about, phenobarb can cause that. And cats are weird because they just do weird stuff, and their cytology is weird. They're weird in clinical practice, and then they're weird on their cytology. They're not straightforward creatures at all. They're very complicated beings.
My cat, what is here?
Oh, do we get to a cat baby? Yes.
He's here, and he confirms.
Oh, yeah, he's in your pictures.
He confirms that he's weird. He's very weird, trust me.
Oh my gosh, I love him. What's his name?
Remy.
Remy. Oh,
yeah.
He is a attractive cat, so he can be as weird as he wants. I have weird dogs. I'm about to get a cat.
Really?
I finally convinced my husband, which he's gonna be like, really, why do you keep telling people I can't? My husband's a vet too, but he loves cats, but he's just never had one in the house before. So he grew up on a farm, and it's not natural for him, I guess, to have a cat in the house. But we have a little more space in the house we're in now. So I actually found one that has cerebellar hypoplasia that's not far from me, and I had a cat that had that a long time ago, and so we're probably going to adopt him.
Have you convinced your dogs as well, or not?
My dogs are actually okay with cats because my Chihuahua I used to have cats, and my Chihuahua's almost 15, so she experienced that. And then my Cavapoo, the people, our friends at the pet sit for her had cats, and she was like, cool, I love cats. So I think we're in a good spot.
Nice.
Anytime I can add more animals, I'm down.
I've seen that you have chickens as well. So you're plenty of animals.
Well, now we have 30 chickens and a mini donkey and a goat. And I've learned that goats don't like to live by themselves. So now we have to add more goats, potentially another donkey. I don't know. It's just going to get out of control. Once you open the floodgates, it's just,
I can imagine.
Full steam ahead. Okay. So for my second case, some of you, I have presented, full warning, I have presented this case before. So some of you may have seen that, hopefully not too many people, but even if you have, you'll still, kick back and enjoy a little deja vu. So this is a 10-year-old male neutered Boston Terrier. And his history was that he had just lethargy that was not getting any better on empirical, treatments, whatever those might have been. And he had an appetence. So really vague signs, nothing at all in the history that was really pointing in any kind of particular direction to what was wrong with him. So he came into the clinic. This was into our specialty clinic. He was referred over. I worked inside of a referral practice, and so I
Mhm.
got to be involved in a lot of these cases. And so this was one that came in on our medicine
Yeah.
in our medicine department. And so on physical exam, he had, again, generalized peripheral lymphadenopathy,
Typical.
and yeah, he also had a fever. And of course, at this point, the main concern was that he had lymphoma. Uh, the lymphoma dogs can become febrile. They don't always, but I know that some people are surprised to hear that they can have fever with lymphoma. So just know that they definitely can. And he did have fever. So the next step obviously was cytology to see
Mhm.
if we could figure out what exactly was going on. So this is his lymph node aspirate, and they ended up submitting multiple lymph nodes. So they submitted submandibulars, popliteals, and I believe prescaps as well. And this one was from I believe it was the popliteal. I don't remember, but in either case, it was one of the lymph nodes. And just looking at lower power here, and then a little bit higher power, we're going to use those same characteristics that I talked about in the last case to get an idea of whether this is lymphoma or reactive. And so looking at the lymphocytes here, we can see that I don't have a neutrophil in the higher objective image, but here you can see some neutrophils here at lower power. And some of them are kind of squished into these denser areas. So you have to be a little bit careful when you're in these more crowded areas, because what can happen is that the cells can get really squished, and then it can be really hard to see their true size, and they might look small when they're not. So taking this whole population into consideration, these areas that are a little bit more spread out, here is a higher objective image of that. And you can see that these cells are pretty large. They fall into the intermediate to large category. So they're not, the most gigantic things in the whole world, but they're too big. They're not small. And we have some red blood cells in here that we can compare the size to. If you don't have a neutrophil, you can use a red blood cell. And the red blood cell is, probably, or the nucleus of this lymphocyte is about 2 times roughly the diameter of a red blood cell, which would make it fall into that category of that intermediate to large lymphocyte. And they all pretty much look like that. So this was representative of the entire slide. There weren't, this wasn't just the only area. Of course, we want to take into the whole population. Lymph nodes are all about patterns, and this was lymphoma. So I felt comfortable diagnosing this as lymphoma. Very straightforward, not really complicated case at all. So I was like, okay, lymphoma, poor buddy.
Next one.
But right. And then so lymphoma, and I thought I'd put some little mistletoe on here to make it a little less sad, if that's possible. So why would I show this case if that was it? That's not the end of the story, right? So this dog had lymphoma, but I personally look at all of the lymph nodes submitted when there's multiple lymph nodes submitted, even if I'm just, even if I have a diagnosis. So I have a diagnosis of lymphoma, but I had other lymph nodes to look at, and I didn't want to ignore those. So even if I'm just popping them up on the microscope, doing a quick scan to make sure that that also looks like lymphoma and there's not anything else lurking in there, I'll do that because I just don't want to miss anything.
Yeah.
And 99.9% of the time, the other lymph nodes are either lymphoma or maybe they're reactive and not affected by lymphoma yet. But there's not things that are, big clinical game changers in the other nodes, except in this case. So yeah, of course. So let's be thorough and let's go ahead and look at the other lymph nodes. So I went ahead and took a look at one of the next lymph nodes. And this is a low power image. So it is, again, tough to make out the size of all of the lymphocytes, but it was a little bit more, I still got a lymphoma vibe in some areas from this one, but there were some areas that were more mixed with smaller lymphocytes. So this one was a little bit more complicated as far as the lymphoid population goes. But what I wanted to show is that there are also a good number of neutrophils popping up in here. So it's not super duper inflamed, but there are definitely a more recognizable number of segmented neutrophils. So that's, that's not in itself that exciting. I might be thinking at this point, okay, maybe there's some necrosis somewhere in here and it's getting a little bit inflamed. I don't see any necrosis in this picture, but whatever. It's just a little bit of inflammation. I'm not really at that point alerted, but it is a little noteworthy. I'm like, okay, there's some inflammation in here.
Mhm.
And so I kept looking around, just make sure I wasn't missing anything.
Oh, hello.
And then, right?
Wow.
I I was like, what are you doing in there? That wasn't supposed to happen. And I'm checking the slides. Is this the same patient? Did I mix up the slides? So I hope everybody can see that these little things here, they don't belong in a lymph node. What are these things? So you had mentioned you guys don't have a lot of fungal infection in the
No,
UK,
we
right?
don't have these neither. I mean,
You don't have them.
no,
You
no,
don't want them. They're
no,
terrible, but
exactly, exactly. We don't want that.
they are everywhere here in Tennessee, in the southern United States. This was in Kentucky, but in, well, really the Midwest and South, and well, those are the only places I've lived, so I know that they're prevalent there. But probably popping up other areas just because of climate change. But this is a differential diagnosis on really any list of a febrile dog, any dog that has skin lesions. I'm kind of giving you guys some clues so you can be thinking about what you think this is as I'm talking. But skin lesions, uh, pulmonary issues, so coughing, tachypnea, um, uh, lymphanomegaly. These can go anywhere and affect really any organ system. So these are yeasts, and they're specifically blastomyces dermatitidis. So this causes blastomycosis. And here are these two. They're tough to photograph because they're kind of 3D, but so everything else is out of focus in the background. But you can see that they have this double contoured refractile cell wall, which is the big boring description for the wall that looks like a double. It's kind of double. You can see the double there, and when you focus in and out, it kind of shines. That's what refractility is. And I'm not telling you that, obviously. Telling
Ah,
anybody else in the
I don't have much
audience.
experience on this, so I'm like
Oh, okay. Well, good.
learning.
Okay, good. Well, so they are, that's characteristic of them, and people will call them the big blue budding balls because they, yeah, I know, it's funny, because they bud with a broad based bud. These two are not budding, but what they will look like are these little snowmen where their buds are broad, so they're not this thin little pinch between the two dividing yeast. They're actually a broad base bud. And so I was just not expecting this
No,
at all. And it made sense with the inflammation in there. Again, even though it wasn't super, super like bad inflammation, it was still there. And these will incite significant inflammation, usually pyogranulomatous, but they can be more separative sometimes too, and more neutrophilic, especially in nodes. I tend to see that. But yeah, so this dog had lymphoma and blastomycosis.
wow.
Yeah. So this is not good for him because the treatment is completely
Of course.
not good. It's like opposite. So I will say that, and again, treatment's out of our wheelhouse, but for blasto, I know the internists that I work with, they will sometimes treat with, I believe, just a low dose of pred to decrease the inflammatory. I don't know, for some reason they they treat with a low dose of pred to do something to help with the systemic effects of blastomycosis. So it's not that they don't use pred, but an immunosuppressive dose of pred,
Of course.
which is what you would want for lymphoma, is certainly going to be an issue for blasto. So I went and talked to the internist. I said, well, yeah, he does have lymphoma. Guess what? He also has blasto. And she was like, what? No, what am I going to do with that? How can I treat that? So this was a complicated case. Complicated, and it wasn't complicated cytologically because we had a pretty clear answer. It
But
was
for the treatment.
shocking. Yeah, but for the treatment, it was was definitely going to be a potential issue. And my pathophys brain goes to, well, what came first? Because I think there are definitely cases of animals that, we think blasto can affect animals that are seemingly healthy, but there's more suspicion, or there might even be proven, it might even be proven at this point that, of course, immunosuppression can predispose animals to these fungal infections. So the suspicion is, well, the dog probably had lymphoma, was becoming immunosuppressed, and then developed and then picked up blasto as well. And what they do is they inhale from the environment, and then it goes to the lungs, and then it disseminates into the body. And I've seen it in a testicle. I've seen it like everywhere. It can go anywhere. So it's always a fun cytologic diagnosis to make when you find them. Also, too, I love infectious organisms just because they allow for an answer. Now, I will say, the more you see, and you know this, like, even though you don't see a lot of fungal infections at all, there can be a lot of overlapping characteristics in the fungal organism. So it's not that it's always straightforward, but here, when I see a typical that typical like snowman look, it's blasto.
Is there any like PCR if needed? Any PCR? There is
so the recommended test is a urine. It's by Miravista, and it's the urine blasto antigen test.
Okay.
And so they run it on urine. It's actually very sensitive and specific, as far as I know. So it's the one that people use to, or the currently recommended one. There are older ones that aren't recommended as much anymore, but that's the one that people probably should be using. That a lot of that's what everybody I know uses to confirm. They'll run it if they suspect it but can't find a lesion. Like basically all fever of unknown origin dogs in the South get a urine blasto antigen test, and then they also use it to monitor treatment.
Nice. Wow. I never had the combo lymphoma blasto, but I had, I think it was 2 years ago, I think I posted some on Facebook as well. I had in a cat a case of a lymphoma and a toxoplasma. Looking for the lymphoma, and I thought, it's a straightforward lymphoma. Then let's look a little bit better. Oh, this looks like toxoplasma. And also in that case, it was what did he come first? Did he come first the lymphoma, or the cat was immunodepressed and then got the toxoplasma, or the other way around? Who knows? But the combo tumor and the infectious, obviously really bad for the animal, but for the pathologist, like wow.
Those are the ones where, like, shakes you out of your sleepy post-lunch state. Like, wow, this is crazy. So this was one of those that I was just not expecting that at all. And I've actually seen at least one more of these now, the combo lymphoma and blasto. I think 2 more, but definitely one more that comes to mind. So it happens with some frequency. So moral of the story is, animals are complex and they can have multiple things happening at once. And if we had not known that this dog had blasto as well, we might have wondered, why is the dog all of a sudden not breathing well? Because it's blasto is going crazy on the immunosuppressive dose of pred. So I don't know exactly how they handled this. I'm embarrassed to say it was lost to follow up in my own clinic. I don't know exactly what happened with this. But a challenging clinical scenario. So one thing that I do get asked about that I'll just end with this case in particular is, from a clinical perspective, some people will say, well, that kind of makes me nervous. Should I be aspirating all the lymph nodes in my lymphoma cases and looking at, submitting all of them? And that's a hard question to answer, because sure, that would be ideal, right? If we could, and we could look at all of them. I don't know. This is not common. So, the majority, obviously that's why I'm presenting it. So to the clinicians out there that are wondering that, I can't tell you not to submit all the lymph nodes. I don't know. What do you think? I think it would be, I think it's sufficient to submit, like 2, if you have generalized peripheral lymphadenopathy. I always like to see more than one submitted, just to correlate. But I don't know that I would stress to submit every single enlarged node. I don't know. it's
Yeah,
hard to answer.
one thing that I would say, yes, I agree that probably a couple of lymph nodes enlarged are enough. What I would then do, that some vets do sometimes, is that they take a sample only from the submandibular, and obviously the
Yeah,
submandibular can have, first you can miss them and take the salivary gland instead, or sometimes maybe the submandibular lymph node is also quite inflamed or has
reactive.
lymph hyperplasia, which can kind of mask partially the lymphoma. So
Yeah,
maybe that is not the only one I would take. But yeah, usually
yeah.
with a couple of lymph nodes, it's enough. And also important, if you take multiple aspirates from multiple lymph nodes, please label them.
Label, yes.
Label, label, please.
Label.
Because otherwise, what's the point? I mean, we need to know. I mean, it's true that most of the time for lymphoma, they all look the same, but not all the time, and they can still be useful. So always label the
Well,
slide.
I totally agree. And one thing that I that it's hard too is if you get multiple lymph node aspirates submitted as one and they're not labeled, and I get one, you know, a couple slides that are very straightforward lymphoma, and then I get a couple more that look more reactive. My question to myself is, did those two come from the same lymph node? And maybe this isn't lymphoma, and those two slides represented that they hit. I mean, it's not common that that happens, but did they hit a reactive lymphoid follicle? And I just got a bunch of cells that looked like lymphoma on this slide. Then on this slide, it's actually just clear that it's more reactive. Versus if I had known those were two nodes, I would say, okay, this node is consistent with lymphoma, and then this one is just reactive, so it's not affected. It's not affected yet, because they don't all, just because you have, you know, peripheral lymphadomegaly and one is clearly lymphoma, it doesn't mean the other one is affected yet, or maybe it's just not effaced yet. So
Absolutely.
yeah, it it complicates things unnecessarily if they're not labeled. So label them.
Yeah.
That's all.
Absolutely. So I think, yeah, there are two things that come in my mind as a sort of take-home message. The first is label the slide,
Yeah.
please. And the other one is, as we both shared in our cases, yeah, as you say, the animal are complex organism, and you can have sometimes multiple diseases. We have seen your lymphoma and blasto. We've seen my barium peritonitis and muscle tumor, or histiocytic sarcoma and muscle tumor. So you can have a combo of different types. So
Yeah.
having one disease that doesn't rule out that there is something else going on. So,
Exactly. Yeah, I like how those came together, and we didn't even mean to do that.
exactly. Yeah, I'm quite impressed by that. So thank you.
Yeah,
Sorry,
that's all. Oh, that was it. We summed it up. That was my key points. Yeah, yeah. And that's just my email if anybody has any questions for me and needs to email. But I know that hopefully you guys are asking, you know, questions in the chat, and
yeah, absolutely.
Anything else?
Absolutely, actually, that if everybody's watching, or I mean, had been watching or is watching, there will be there is a chat on the right where you can write questions, and this question can also come after the talk, like now, right now that you're listening, we are going to answer to them absolutely, and obviously. Please, or you know, if you're interested, you know, keep following us on the Veterinary Cytology Coffee House Facebook page, Instagram page, and the website as well, and the same for my Veterinary Cytology page. I think it's fun. I think it's fun to share knowledge, share information, and also have some fun sometimes.
Yeah, I totally agree. Yeah, and I showed you that picture of that hat I almost wore. You guys got away with this more professional hat that I went with, because the first one was going to cover my entire face except for a little hole. I thought that, you know, I go with something a little more professional, but yeah, right, exactly. But yeah, no, this has been so fun. I'm glad you invited me to do it and came up with that idea.
For accepting, because you know how many people have asked me over the years, you know, you should ask Kate to do something together, and there was always yes, we had to, and then we found, I think, you know, the right time, and I think it came up quite well. I mean, I really enjoyed it, and I think that's important. When you enjoy doing something, it means that you know that it's good.
It's clear. So, yeah, it totally is.
Super. So thank you, Kate. Thank you, everybody, for watching, and have a Merry Christmas, have a festive time, Happy New Year, or whatever. Happy
holidays for everybody who doesn't celebrate Christmas.
Exactly, absolutely. Just let's try to have some, some fun, some rest, and some time with our relatives. I mean, being obviously careful of this current situation.
Yeah.
And that's all. Thank you so
Yeah. Hope
much.
to do it again sometime. All right. Thanks, guys.
Thank you, guys. Bye bye.